And pleasure to welcome Dr. Sunil Kumar, who happens to be the Additional Director of Trivandrum Institute of Palliative Sciences, a WHO collaborating center for training and policy and access to pain relief in Trivandrum, Kerala. He has a diploma in palliative medicine from India and Cardiff and a master's in palliative medicine from Cardiff. With an extensive 15 years of experience into palliative medicine, he oversees the clinical services, academics, and research of Pallium India. So, Sunil sir, welcome to the session, and we do hope to have a very interactive session as always with you. Over to you, sir.
Thank you, Stephania, and good afternoon, everybody. So you have already covered basics of pain management and pain management with non-opioids and as well as peak opioids. Today we are planning to cover the step 3 opioids or opioids for moderate to severe pain. So let me share my PowerPoint presentation. Is it visible?
Yes, sir. Perfect.
Okay. Okay. So I am straight away going into the topic. So just understand that we are not only going to talk about the technical details of opioids, but it is also important for us to understand the prices of different opioids, which is very important because whenever we prescribe, we don't know whether patients are going to buy these medicines because many of them may not be able to get this medicine because they are financially very poor. So one of the main reasons for poor symptom control is the patients may not be taking medicines as prescribed, and this is the price of different medications is one of the main reasons. So all of you know the WHO analgesic ladder, which has 3 steps, and now we are on the third step where opioids are used for moderate to severe pain. So can anybody name the opioids which are available in India in the third step of WHO analgesic ladder?
You can post your entries in the chat box or unmute yourself and say.
You can unmute and speak so that we can go fast. Yeah, fentanyl, morphine, buprenorphine. Okay, what else? Tramadol. Okay, morphine, fentanyl, buprenorphine. I am specifically talking about the opioids in step 3. That is opioid for moderate to severe pain. So which are those? All of you have written different opioids. Yeah, morphine, fentanyl. Anything else? Okay, yeah, it's methadone. So we have 3 opioids in India which can be used to treat severe pain. Those are methadone, fentanyl, and morphine, methadone, and fentanyl. Okay, so now we are moving on to a patient story. You can see a patient here. When you see a patient like this, what would be your most important concern regarding this patient? Anybody? Ataxia, yes. Dr. Roshan, yeah. Is malnourished, seems to be in pain. Yes. Anything else? Person looks in distress. Yeah, depression. Okay, thank you. Um, yeah, what you have told is right. But when we see a patient like this, we can see that he is in distress due to pain. His facial expression says it, isn't it? So that should be the primary concern for us. So um, this patient is a 56-year-old man with carcinoma of the larynx, and he has undergone surgery and radiotherapy. He has a tracheostomy, and his main problem is the pain around neck, which he says is continuous pain, and that quality continuous pain, and he score it 10 by 10. And he also says he was unable to sleep because of this pain for the last 2 weeks. So, how will you manage this patient if this patient comes to you? WHO ladder. Okay. First, start with step one of WHO ladder. Okay. Uh, Anybody else? Is he clinically controlled? I will start with step two plus adjuvant as it is 10 by 10. Okay. Give medicines for helping in sleep. Yes. Um, yeah. What is the pain score of this patient? It is 10 by 10, isn't it? So it is severe pain. So if the patient has severe pain, which step of WHO analgesic ladder should we use? The first step of WHO analgesic ladder is to treat mild pain, whereas second step is to treat moderate pain, and third step is to treat severe pain. So this patient has severe pain. Yeah. So we should straight away go into step three. So some of you told step one, two, etc. But I would like to ask you a question. If you have pain, how fast would you like to get relief? Immediately, isn't it? So uh, that's the beauty of WHO analgesic ladder. Even though it is a ladder, if the patient has severe pain, you can start at step three. You need not first start with step one, and after 2 or 3 days, then move to step two, and then maybe step three. So it will take 1 week to go to step three. By the time the patient may commit suicide if they are in severe pain. So we should give pain relief as fast as possible. So that's our aim. That's why we have WHO analgesic ladder. Okay. Uh, so you can see this patient after some time, after an hour or so, he is smiling. So what made this possible? Okay. This is with um, morphine. Uh, so this patient received an intravenous morphine titration. Okay. So for faster pain relief, you can use intravenous morphine. So it has to be given in a titrated fashion. So how will you do an intravenous morphine titration? Uh, So there are various morphine titration methods available, but this one is developed by Dr. Rajgopal and his team. So this is what we use here. So we use injection morphine 1.5 milligram at 10 minutes interval. So injection morphine at every 10 minutes interval. So what is the immediate side effect you expect by giving injection morphine to a patient? What is the immediate side effect? Okay. Sedation, vomiting, nausea, vomiting. Yeah. So we have to expect that a patient can have nausea and vomiting. So you have to give an antiemetic to prevent nausea and vomiting. So we usually give injection metoclopramide. So first give injection metoclopramide followed by injection morphine 1.5 milligram at every 10 minutes interval. And how long would you like to, or how long would you continue to give it, or what's the endpoint of IV morphine titration? So either the patient who should have satisfactory pain relief, or the patient develops sleepiness, whichever be the first. So all the patients may not have satisfactory pain relief. Some of them may develop sleepiness rather than satisfactory pain relief. So you have to stop the trial then. Okay. So our patient, for giving intravenous morphine trial, you can make a chart like this, which includes time, pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy, and the dose of injection morphine. So you can see the time is charted after every 10 minutes and the pain score. So first you will chart the time, pulse rate, blood pressure, respiratory rate, and you will ask the pain score of the patient. It's 10 now, and you will see the patient is drowsy or not. Patient is not drowsy, then you will give injection morphine 1.5. Wait for 10 minutes, and again check the vitals and ask the patient's pain score. So now it's 7. Patient is not drowsy, you will give another 1.5. So you can see at 10:30 the patient pain score has come down to 1. So that means patient has a good pain relief. Patient is not drowsy. So this is the indication to stop the injection morphine titration. So this patient received 4.5 milligram of IV morphine with good pain relief. So is this patient an inpatient procedure or outpatient procedure? Intravenous morphine titration. Yeah, 1.5 milligram is a very small dose, and yeah, you have to give it slowly. Yeah, you can give it on an outpatient basis. You need not admit the patient for intravenous morphine trial. We do at least 1 or 2 trials per day. Okay. So this patient received 4.5 milligram of IV morphine, and he has very good pain relief. So how will you discharge the patient, and what would be the dose of oral morphine you will give the patient? Please unmute and speak. 10 milligram for hourly. Okay. 2.5 milligram. So can somebody explain why they have or how they calculated this dose? 10 milligram for hourly.
Hello.
Yes.
So the patient was having severe pain. So just to relieve that pain, we again IV morphine. But later patient will again experience the same kind of pain. So we have to start with oral morphine. And
Yeah.
as the morphine availability is around 4 hours in the
Yeah.
action, then we
Yeah.
can ask for 10 mg for 4 hourly, 6 times in a day, which is comparatively impossible. So I ask for 4 to 5 times in a day at least,
Hmm.
4 hourly.
So why for 10 milligram?
Because no, it's like I can't justify why. I mean, I start with 10 mg and 5 mg for breakthrough.
Okay, okay. Okay,
I
thank
don't
you,
have any
Dr. Rashan.
reason.
Yeah, it's okay. Anybody else?
Hello.
Yeah,
Yeah. So 1 milligram morphine is of IV morphine is equal to 2.5 of oral.
yeah.
So 4.5, 4 gram, 4 milligram morphine will be equal to 10 milligram of oral morphine.
Okay, thank you, Dr. Pratap. So what you what he has told is right. when you convert IV morphine to oral morphine, the usual conversion ratio is 2 to 3. Okay, but this is applicable when the patient has achieved a sustained blood level. That means opioids will take about 5 half-lives to have sustained blood level. So in this patient, the patient has not attained sustained blood level. We have the patient has received morphine during 1 hour only, and we are converting it into oral morphine. So we cannot multiply it by 2 or 3. And there's a study which was conducted by Dr. Ajobal and his team, and they have converted the intravenous morphine directly to oral morphine, the same dose. Okay, so for 4.5 milligram to the nearest possible oral dose, that is 5 milligram. So and this can be converted into 5 milligram orally and every 4 hour day. So, but if the patient has been on continuous IV infusion for more than 24 hours, then I would go with what Dr. Pragar has told, multiplied by 2 to 3. Okay, so if the patient has taken 20 milligram over 24 hours IV morphine, then I would start with 60 milligram of oral morphine per day. But here the patient has received just a trial over 1 hour, so the blood level is not sustained. So I would convert this IV morphine, same dose of IV morphine to oral morphine. So this is how you give oral morphine. You can see we can give 5 milligram of oral morphine because the tablet available is 10 milligram. So instead of wakes up, you can say it's 6 a.m. and then 10 a.m., 2 p.m., 6 p.m. and instead of bedtime, you can say it's 10 p.m. Okay. So for easier understanding, it's every 4 hourly. But we also know that if the patient has severe pain, usually they will be sleeping by morning. At 6 a.m. they will be sleeping. We need not wake them up. Give the first dose whenever they wake up. And if they want to go early to the bed, give the bedtime or the 10 p.m. dose can be also relaxed. And the bedtime dose is always double of the regular dose. So this patient is taking 5 milligram regularly, but at bedtime he is receiving 10 milligram. And in addition, you can also give SOS doses. So the SOS dose would be the same as regular dose, that's 5 milligram. Okay, and there are many places where injectable morphine is not available, and in such places we can use oral morphine. And if the patient is opioid naive, that is patient is not on any opioids, then you may start with 5 milligram morphine every 4 hourly and SIS. If the patient is taking weak opioids like tramadol, codeine, then you may start with 10 milligram 4 hourly and SIS dose. So our patient, the patient whom we saw earlier, he was started on 5 milligram morphine every 4 hourly with an SIS dose. He was relatively pain-free for the last 2 weeks, but then his pain was increased and he started taking more SIS dose. He said, I took 4 SIS doses for the last 4 days. What shall we do now? And I already told that he has taken 4 SIS doses. So how frequently can we give SIS dose of oral morphine? There are 2 questions. Anybody?
Hello.
Yeah.
Hello.
Yes, please.
Uh, uh, First, I will increase the 4-hourly dose by 50%, as
Yeah.
the person needs more than 4 SOS dose.
Hmm.
Either 2 or more than 2 rescue dose, breakthrough dose, then you should increase the 4-hourly dose by at least 50% first. Then
Yeah.
we need to increase the 4-hourly dose.
Okay. Thank you, Dr. Samita. So what she told is right. Whenever the patient takes 2 or more than SOS doses, PRN is same as SOS dose. Okay. Then increase the dose by every 30 to 50%. In this patient, he is taking 5 milligram. So 50% of 5 milligram would be 2.5. So you can increase it to 7.5 milligram every 4 hourly, or even 10 milligram 4 hourly should be okay for this patient. And the dosage can be increased every 24 hours, not 2 to 3 days. Okay. And how frequently can we give SOS dose of oral morphine? I saw that as many times as patient requires, but what should be the frequency between 2 doses, or what should be the time interval between the 2 doses? Anybody? 4 hourly. Okay, Dr. Ronaldo says 4 hourly. Any other answers? Okay, so we have to understand a little bit of pharmacology about morphine. So this is the poppy plant, and you can see this is legally grown only in 3 states of India: UP, MP, and Rajasthan. So you can see the seed-like things, which is known as pod, pod, and the farmers will make small cuts on this pod, and the sap which is coming out, they will collect it and dry it in sunlight, and this will be transported to government opium and alkaloid factories, from which they will make morphine powder, and various preparations are made from this morphine powder. So morphine is absorbed from the upper small intestine, and if you powder the morphine, then it has a it would be bitter. So that's what we have to remember. So whenever you powder the morphine, please sweeten it with sugar or some fruit juice. And there are various routes through which you can give morphine, but sublingual, buccal, or gingival is not usually advised. And after absorption, what happens? So it undergoes metabolism in the liver. So the most important metabolism, or the main metabolism, happens in liver. When it reaches the GI tract, it is absorbed into the blood vessels of GI tract, and from there it will go into the portal vein and to the liver, where metabolism takes place, and then metabolites are liberated into the systemic circulation. So what are the metabolites of what are the metabolites of morphine? Mainly there are 2 metabolites. Okay. So these are morphine 3 glucuronide and morphine 6 glucuronide. In short, it is M3G and M6G, and there are many other minor metabolites. And what you have to understand is morphine, 90% of morphine is converted into metabolites, and Out of this, M3G is formed in large quantity, about 45 to 55%, and M6C in 5 to 10%. This ratio varies between books. So whatever it might be, M6C is formed in less quantity. And the M6C is the component or metabolite which will give you the pain relief. And it is formed in less quantity. So when you administer the morphine orally, it has to go into GI tract. From the upper small intestine, it is absorbed. Then in the liver, it undergoes metabolism and then liberated into systemic circulation. So this process will take some time. So the pain relief will start by about 30 minutes, but the peak will be by 1 hour. So it is always better to wait for 1 hour before administering the next dose. So you have administered the regular dose at 6 a.m. When the patient had pain. And by 6:30 p.m., if the patient complains of pain, it would be better to tell him that we would wait for another 1 hour in which we expect that you will get pain relief, because it will take about 1 hour for maximum pain relief. Okay, so 1 hour is the answer for this. So our patient, Mr. X pain was stabilized with 10 milligram every 4 hourly, but the patient says it is very difficult to take it every 4 hourly. It is very common, isn't it? Even when we take some antibiotics like amoxicillin 3 times, it's very difficult for us. How many of us would complete 3 times for 5 days? So this patient says it is very difficult for me to take every 4 hourly. And he also says you, if you can give it less frequently, I am willing to take it. Can you help me? So what do you do for this patient?
So if he has a hello,
Yeah.
if he has a good relief with 10 mg 4 hourly, then you can transfer the patient to like 30 mg SR or
30 mg
sustained,
SR.
sustained release morphine SR.
Okay. Yeah. So that's an option. So you can administer sustained release morphine. This patient is on 10 milligram 4 hourly. That means this patient is taking 60 milligram of oral morphine per day. So the duration of action of sustained release tablet is 12 hours. So 60 milligram you can divide into 2. That is 30 milligram SR. That is sustained release 2 times a day. But you have to also understand that sometimes this patient can have pain in between. So you have to give SOS dose of morphine. So which one would you use as SOS dose? SR morphine or immediate release morphine, the normal morphine? You have to use the immediate release morphine or 4 hourly morphine. Okay, that is immediate release morphine. The same dose, 10 milligram immediate release. Immediate release is also known as fast acting morphine. So what are the preparations of morphine available? And there are aqueous solutions, that is syrup, available in some places. Tablets and capsules are available, both immediate release as well as controlled release. But controlled release will be 3 or 4 times costly than immediate release tablet. Then injections are available and the strength will be variable from state to state. In Kerala, it is 15 milligram ampules are available, but I know in Tamil Nadu it is 10 milligram. So our patient, he is on 10 milligram 4 hourly for the past 6 months. He was comfortable with that, but then he was brought to casualty on.
Discharge card ಬರ್ತಿರಲ್ಲ ಸರ್, ಹಳೆ discharge card
So this patient was brought to the casualty with excessive drowsiness, and you investigated the patient, and you found that there is total count is elevated, blood urea is normal, serum creatinine is 5 milligrams per deciliter. Will you do anything with morphine dosage? Anybody? Okay, taper the dose. Why should you taper the dose?
Because maybe the metabolites of the morphine is causing kidney damage.
Sorry?
The metabolites of the morphine is causing kidney damage probably.
Okay. Okay. Anybody else? Skip the dose. Dr. Shivani says skip the dose. Okay. So I saw one question in the chat also. So if it is metabolized, if morphine is metabolized in liver, why should we decrease the dose of morphine hepatorenal syndrome? Okay. What you have to understand is morphine is excreted from the body by glomerular filtration. Okay. So what happens in if the patient has chronic kidney disease, the M6C, morphine and its metabolites actually accumulate in renal failure, and the half-life of M6C will increase, which will cause many toxic symptoms, and patient will be drowsy, there will be jerky movements, patient can have delirium. So this patient is drowsy because the morphine and its metabolites are not excreted from the body. Okay, the patient will be extremely drowsy. So what can we do in this patient? Maybe we can skip 1 or 2 doses till the patient becomes alert, and then start with a lower dose. And possibly instead of 6 hour, 4 hourly, you may give it less frequently, like maybe 6 hourly or 8 hourly, 12 hourly. And even there are some patients who undergoes dialysis, they might need only single dose until the next dialysis. Okay, so according to the severity of chronic kidney disease, you have to adjust the dose. Or another option is you can use renally safe opioids like fentanyl or methadone. So we reduced the dose of this patient to 5 milligram. And I would like to tell that morphine doesn't cause any kidney damage as such, morphine and its metabolites. But it is because the morphine and its metabolites accumulates in renal failure, and that's why the patient develops drowsiness. Okay. So this patient was on 5 milligram morphine every 8 hourly because of chronic kidney disease. This patient, because of his advanced disease, unable to swallow anything including morphine, and the patient is at home. So he's unable to take morphine also. And now he is in severe pain. So what will you do for this patient for pain relief? Okay, transfer to fentanyl patch, morphine patch, fentanyl patch, maybe an opioid patch. Okay, adjunct drug. So this patient is at home. Who will, I don't know how, put an NG tube, help in feeding and medicine. Okay. Suppose this patient is end of life. He's going to die in next 2 or 3 days. and patient is not in the hospital. So what would be the, there are many options, as you are told, but what would be the, what would be a simpler option? Okay, morphine patch is not available, for your information. Okay. IV morphine, yes, IV morphine is an option, but the patient is at home. That's the problem. Who will give injectable morphine for the patient when he is at home? Okay, what are the routes through which we can administer morphine? Yeah. What are the routes through which we can administer morphine? As you all know, oral route is the most common route, followed by intravenous or subcutaneous route. Then what? Which are the other routes? Depot IM injections are not available. Correctal. Dr. Roshan Kumar says correctal. Okay. Okay. So we can administer morphine correctly also. Then epidural, intrathecal. So out of this, which route will you select if the patient is unable to swallow anything and the patient is at home? You can give morphine correctly, isn't it? So you may give the same dose of morphine correctly. This patient was taking 5 milligram 8 hourly. So the same dose can be given correctly. And it might be better to use a fast acting tablet, because if modified release tablets are used, that has to be crushed and make it you need to make it as a paste, which will then will not have the properties of a modified release tablet. So fast acting tablet would be better one to use. And parenteral route is comparable to oral route in all aspects. So if the patient was taking 5 milligram 8 hourly means, and the same pain relief can be achieved by parenteral route. And even some literature says parenteral route is more superior to per oral route. Okay, now we are leaving our first patient, and this is another patient. Mrs. K, 55-year-old lady with the carcinoma of the colon, has abdominal pain, which is continuous in nature, and patient is on 10 milligram morphine 4 hourly. But her pain is controlled as of now, and you can see she doesn't require any excess dose of morphine. So her pain is stabilized on 10 milligram of morphine 4 hourly. So as the patient told the doctor that it is very difficult for me to take it every 4 hourly, the doctor has asked them to replace the morphine with a fentanyl patch. But the patient came to you next day and told you that I removed the fentanyl patch after 5 hours as I had no pain relief. What will you do for this patient? Anybody? Okay, can we give SR tab? SR tab, you need to crush it, isn't it? When you crush, the sustained release property will be lost. So it will not be possible. Can divide into Yeah. SR morphine orally. So I can see all of you want to convert it into SR morphine rather than fentanyl. But Dr. Pragar has some other opinion. He says fentanyl will take about 6 hours to act. Okay, so let's see. So a few things about transdermal fentanyl patch is that when you actually morphine is hydrophilic, that is water soluble, but fentanyl is lipophilic, fat soluble. When you apply the fentanyl patch to the skin, uh, first it will create a subcutaneous tissue storage. Okay, for this storage to occur, it will take about 8 to 12 hours. Okay, so maybe once the subcutaneous tissue depot is created, fentanyl is constantly released into the systemic circulation. But for this to occur, it will take about 8 to 12 hours. But our patient removed the fentanyl patch by after 5 hours. So that might be the reason why the patient didn't have pain relief. So whenever you prescribe fentanyl patch for a patient, we have to tell them that this is what is going to happen. You have to wait for 8 to 12 hours, and you also should be able to give pain relief during this 8 to 12 hours. So you have to continue the opioid which the patient was taking previously. So in this patient, she was taking morphine 10 milligram for hourly. So you have to continue morphine till 8 to 12 hours, even if you apply the fentanyl patch. And as you know, the duration of action is for 3 days. And when you apply the patch, you should not shave the area, because shaving will produce abrasions in the skin, which can increase the absorption. And temperature is also another problem because it will also increase absorption. And for a country like us, where there is a lot of sweating, the application of transdermal fentanyl might be a problem. And most importantly, this is something which we have to understand. It is not suitable for patients with unstable pain. So unstable pain means the patient's pain is increasing and decreasing very frequently. So when you prescribe fentanyl patch, it can liberate only constant amount of fentanyl into the systemic circulation. We cannot alter the dose. So fentanyl patch is not advised for patients who has a who has an unstable pain. But if the patient's pain is stabilized with short-acting opioids, then we know that this patient requires this much dose of fentanyl. So that patient can be converted into fentanyl patch. And there are 3 preparations available: injection, then transdermal fentanyl patch, and oral transmucosal fentanyl citrate. In short form, it is OTFC, which is like a lollipop. This is especially useful for patients who has a movement-related pain, incident pain. So incident pain is a short-lasting pain. So when the patient plans to walk, they can rub it over the oral mucosa, which will give instantaneous pain relief. And compared to morphine, this is about 100 to 150 times more potent. For clinical purpose and easier calculation, it is taken as 100 times more potent than morphine. So if you calculate that way, then 60 milligram of oral morphine per day would be equal to 25 microgram per hour transdermal fentanyl patch. So this is one thing which you have to remember, so that when you convert from another opioid into fentanyl, it will be easy. So now I am moving on to another patient. Mr. P, 70-year-old man, has carcinoma of the lung and is complaining of throbbing pain on right front of chest which is continuous in nature, and he scores 5/10. He is a non-epileptic and is on levetiracetam 500 milligram BD. How will you manage his pain? Anybody? What would be your what analgesic would you use in the situation? This patient has a moderate pain, isn't it? So which step of WHO analgesic ladder should you use? Yeah, step two plus adjunct. Yes, yes. So from step two, which medication are you going to use? NSAID plus weak opioids, tramadol plus tryptamol. Yes. In the second step of WHO analgesic ladder, it's opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuncts. Yeah. Okay. But I know that the faculty might have told you that if tramadol has or a few points which is important regarding tramadol is tramadol can reduce the seizure threshold. Okay, tramadol reduces the seizure threshold. So if you give a tramadol for this patient who is non-epileptic, there is a chance that you may precipitate seizure. Okay, so you have to be a little bit careful here, but this is more true when you use more than 400 milligram of tramadol, or when you give fast IV push of tramadol. Okay, so maybe in this patient, if you want to safely start on analgesic, maybe you can use even a low dose morphine, maybe 2.5 milligrams 6 hourly, something like that. So here we have another patient, Mrs. P, who is on morphine 50 milligram 4 hourly. She attends your clinic with severe pain. And you have only injection pentazocine and oral morphine tablet with you. So how will you manage this patient? How can we manage this severe pain? Which one would you choose? Anybody? Patient is in severe pain. So what are you going to use? Yeah, injectable form. That is injection pentazocine. That's what available with you. Okay, so we have to understand little bit of opioid receptors here. So all of you know that opioid, for a medicine to be qualified as opioid, it should have two properties. Its action should be produced by combining with opioid receptors, and it should be reversed by naloxone. So these are the two properties for a medicine to become opioid. Okay, so mu, kappa, and delta are the main opioid receptors, and there is something called as nociceptin like peptides, which is also an opioid receptor. And according to the action on receptors, opioids can be classified into three: agonist, antagonist, and agonist and agonist. So what is an agonist? Agonist means these are medications which will combine with opioid receptors to produce physiological action. So physiological action is pain relief, and there are many other effects. Okay, so agonist will provide you with pain relief. What is an antagonist? So what are the examples of agonist? Most of the opioids which we know are examples of agonist. Morphine, methadone, fentanyl, tramadol. Those all are agonist opioids. What is the example of an antagonist opioid?
It's
Antagonist?
naloxone. It's
Yeah,
naloxone, sir.
naloxone. Yes, correct. Uh, so, uh, mm, suppose I give naloxone to you. What would be the action in your body?
It will completely antagonize the effect of morphine. It is a complete competitive antagonist.
Yes, that's true. But if you are not taking or if you have not taken any opioids, it doesn't have any action in your body. Naloxone, it will competitively inhibit an agonist, isn't it? So antagonist will inhibit the action of an agonist. And there is another group of opioid called agonist antagonist. So that means it will act as agonist at some opioid receptors, whereas it will act as an antagonist at another opioid receptor. So agonist antagonist, there are many medications, but the commonly used one are buprenorphine, pentazocine, liverphenol, butorphanol, etc. Okay. So look at this graph. This is the main difference between agonist and agonist. So agonist means you can see the graph on the left hand. Suppose you take morphine, which is an agonist, and this patient has a severe pain. Suppose it is 10 by 10. This is the 10 by 10 pain, and you give 1 milligram of morphine. That will give this much pain relief. And as you increase the dose of morphine, that will give corresponding pain relief. And when you increase the dose till here, that will give complete pain relief. So that means as the dose of agonist is increased, there will be corresponding increase in pain relief. Theoretically, you should get 100% pain relief. But what happens in case of agonist antagonist? Suppose you give an agonist antagonist like pentazocine. As you increase the dose of agonist antagonist, there will be corresponding pain relief. But it is up to a point. You can see at this point at which even if you increase the dose of agonist antagonist, you can see the curve is flattens. Curve flattens, and that means there is a maximum dose that can give pain relief, beyond which there will not be any pain relief. The toxic effects will be more. Okay, so that's the main difference. So this is known as ceiling effect for analgesia. Agonist antagonist group of medications or opioids have ceiling effect for analgesia, whereas agonist group of opioids doesn't have ceiling effect for analgesia. So that's the main difference, ceiling effect. And pentazocine is an agonist at kappa receptor, whereas it is a weak antagonist at mu. Our patient is already taking morphine, isn't it? So morphine is a mu agonist. So what will happen if you give injection pentazocine to a patient who is on high dose of morphine? So pentazocine will displace morphine from the mu receptor. Okay, and then pain relief will be due to the action of pentazocine on kappa receptors. Another important thing is the opioids which acts on mu receptors are the potent opioids. So here now the pain relief will only be due to kappa receptor because pentazocine has displaced morphine from the mu receptor. So instead of pain relief, the patient will have more pain. So that's what is going to happen. So in this patient, what can we do? Take a detailed history, whether the patient has missed any dose. Probably he might have missed a dose. Otherwise, also, if you have only injection and pentazocine, you have to manage the patient with SOS dose of morphine. So now I am moving on to adverse effects of opioid. So adverse effects can be divided into side effects and toxic effects. So what are side effects? Side effects means these are adverse effects with therapeutic doses. Okay. So the patient is taking opioid and the patient has good pain relief, but even then the patient may have some adverse effects which are known as side effects. So what are the side effects? Can anybody tell? One is constipation. Respiratory depression, nausea, dependency, sedation, nausea, vomiting, pruritus. Yeah. So constipation, nausea, vomiting, sleepiness and tiredness. These are the common side effects. But there are some rare side effects: itching, dry mouth, urinary hesitancy. These are the rare side effects. Okay. And constipation, the opioid has many action in the gastrointestinal tract. It will produce constipation because of the contraction of smooth muscles. There are two types of muscles in the intestine. One is longitudinal muscles and the other one is transverse. It will produce ring contractions in the GI tract, which will produce constipation. In addition, it will also increase the absorption of water and solutes. Then it will increase the tone of sphincters. So all this will contribute to constipation. And most importantly, what you have to understand is constipation will be there as long as the patient is on opioid. So it is not wise to give SOS dose of laxatives. You have to continue the laxatives on a regular basis. And it occurs in almost 95% of patients. Okay, so whenever you start a patient on opioid, you have to prescribe laxative. And it is not a laxative, you have to use stimulant laxative. So the examples of stimulant laxatives are bisacodyl, senna, and sodium picosulfate. Okay. Then nausea and vomiting, and it occurs in almost 1/3 of the patients. But compared to constipation, what happens here is this nausea and vomiting, it will be reduced or it will be over by maximum of 1 week. So maybe for the first 3 to 5 days, you have to give an antiemetic. And this is because the opioids acts on chemoreceptor trigger zone in the brain. So that will cause nausea and vomiting. So the most abundant receptor in CTZ is type 2 dopaminergic receptor, that is D2 receptor. And these are the medications which are usually used for treating nausea and vomiting. The strongest D2 blocker is haloperidol, followed by metoclopramide and domperidone. Okay, and 5-HT3 blockers are not the usually preferred one. This is the usually preferred antiemetic for opioid-induced nausea and vomiting. Then the patient can have sleepiness and tiredness. This is also self-limiting, which can occur on initiation of opioid. Now, toxic effects. What are the toxic effects? This is again an adverse effect when the administered dose is higher than the required for pain relief, or when the patient's pain has poor response. So when you administer more than required dose, it causes some adverse effect which are known as toxic effect. Usually it is manifested by delirium, myoclonus. These are jerky movements in part of body or maybe whole of the body. Then the patient will have extreme drowsiness. Okay, so some of you were talking about respiratory depression. I have not included them in side effects anyway. Now, how true it is. We know that if we look at the pharmacology books, first they will be talking about respiratory depression. So how common it is? So this is a systematic review from 2003 about oral opioids. You can read this. Most of the patients takes their medications by mouth, combined with, and usually it will be gradually increased, which ensures that respiratory depression is unusual. Okay. And it continues to say that when respiratory compromise does occur, you should seek an alternative explanation for this. Is there a pneumonia? Is there a pulmonary embolism, cardiomyopathy, or are you administering a benzodiazepine along with opioid? So respiratory depression is very unusual. I have not seen any case of respiratory depression during the last 18 years of my experience in palliative care. I have given prescriptions for maybe at least 25,000 of patients for morphine or methadone, but I have not seen any case of respiratory depression. Even I have given many injection morphine, continuous morphine infusions, fentanyl infusion. I have not come across a respiratory depression, even with IV infusions or subcutaneous infusion. So if you use it carefully, it will not produce respiratory depression. So this was another concern, opioid producing addiction, or yeah. So can somebody tell me what is addiction?
So which causes physical as well as psychological dependence?
Yeah. Yeah. So there are two words. One is what we have to understand is substance abuse as a result of medical use is low. And there is some confusion between physical dependence and psychological dependence. There are psychological dependencies known as addiction. Okay. So what is psychological dependence? So it says, what is the difference between this psychological dependence and physical dependence? I'm just giving a simple example. Many of you might be having a coffee in the morning. So maybe for the last many years, suppose you don't get coffee in the morning one day. What happens? Dr. Shivani, you are muted.
So it may cause headache.
Headache, irritation, yawning. Okay. Is that psychological dependence, addiction?
Yes, that is psychological, sir.
Okay. Anybody else have difference of opinion? Actually, that is not psychological dependence, because if you have psychological dependence, you will have craving. So you know that in the other your neighbor's house, coffee powder and sugar has kept, but they have locked the house. Even if so, you will break into the house, neighbor's house, and will get coffee powder and sugar. So if you are doing, then you have addiction, but otherwise you don't have addiction. Your body is telling you that today you have not given me coffee. That is manifested as withdrawal reaction, which can occur in case of many other medications also. So that's a usual reaction uh, of our body. But that's the difference between physical dependence. Physical dependence is manifested as withdrawal reaction, whereas psychological dependence is manifested by withdrawal reaction, craving, all the other manifestations. Okay. The definition by American Academy of Pain Medicine and American Academy of Addiction Medicine. They says it is a primary chronic neurobiologic disease. What you have to understand is they name it as a disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. So if you have a gene for addiction, that's what neurobiology genetic means. If you have an addiction which predisposes to you for addiction, then suppose you have a friend who is working in operation theater where all the opioids are available, and your friend is having psychological dependence. So the environment becomes favorable. All the factors are favorable. Then there is a chance that you may have get addicted, or you may be psychologically dependent for that medication. So that is what is known as psychological dependence, and the manifestations are impaired control over drug use. You will not take the medicine according to the prescribed dose. You will continue to escalate it very frequently, and you know that this is not for pain I am taking, this is for some other thing I am taking, and you know it is going to cause harm to you, but still you will use it, and there will be craving. Okay, so I am moving on to a prescription. Mr. X has severe pain and you are starting him on morphine. Can you write a prescription? His serum creatinine is normal. Can anybody tell us what would be the prescription? Anybody, please?
So we will start with 5 mg 4 times in a day and maybe 2 tablets and bedtime for 3 days and then evaluate.
Okay. What else you have to prescribe?
We have to prescribe like pan40 antiemetic and maybe an adjuvant in the form of pregab or tritomer.
Okay. So the patient has severe pain, but we need to start him on morphine. So it should be morphine, tab morphine, 10 milligram, half. What are the timings you have to write? Half at 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 1 at 10 p.m. And the patient can also take half SAS. You have to write how long are you giving the medication and how many numbers of morphine are you dispensing. So according to NDPS Act, these all are necessary. You should write the patient's name, age, address, then the name of the medicine in capital letters, the number of days along with number of morphine tablets you prescribe. Then you should write, this is not NDPS, the bisacodyl and metoclopramide. You know that nausea and vomiting is self-limiting. After 3 days, you can withdraw metoclopramide. Okay, make it SOS. But you have to continue the bisacodyl. Then you have to put your signature, name, medical council registration number, and your address. So these are necessary as per NDPS Act. So we have another patient who was on tab tramadol 50 milligram 8 hourly for pain. Now she has severe pain and has started on 5 milligrams 4 hourly. So the person started him like this. He added morphine along with the tramadol, morphine half Q4H, then syrup liquid paraffin 15 ml. Any of you can correct this prescription?
So we should not start two drugs from the same group.
Okay. So what would you like to do here?
So we may add a NSAID with morphine.
Okay, thank you. Anybody else?
We should change the liquid paraffin to bisacodyl.
Yes.
If we want to continue the morphine.
Yes, yes. Thank you.
We can start
Yes.
We can start paracetamol also along with morphine. Either morphine or tramadol should be prescribed. And with tramadol, we can also add paracetamol according to the pain score.
Okay. Thank you, Dr. Manglik. According to NDPS, what all needed. You should not combine. You can see tramadol is an opioid used to treat mild to moderate pain, whereas morphine is an opioid used to treat moderate to severe pain. You should not combine this. So if you need as opioid to treat severe pain, then you give only morphine. It is pharmacologically not correct to continue a weak opioid along with a strong opioid. So you should, this patient was already on tramadol, 50 milligram 8 hourly. So you should stop tramadol, and the patient is already on a weak opioid. So when you start him on morphine, you can directly start out with 10 milligram 4 hourly. Then instead of liquid paraffin, because it is not the drug of choice for opioid-induced constipation, it is regular stimulant laxative should be used. So bisoprolol should be in place. You may continue liquid paraffin, or you may stop it and try. So bisoprolol should be there. Okay, and this is also you need to understand the comparative prices of different opioids. And if you give morphine 5 milligram 4 hourly for a patient, and he is getting good pain relief, then he is taking total 30 milligram per day, and that would cost 3 rupees 50 paise approximately. To get the same pain relief, you have to give about 300 milligram of tramadol, which will cost anywhere between 25 to 50 rupees per day. Whereas to give the same pain relief, you have to use 12.5 microgram of fentanyl patch, which will cost about 100 rupees per day. Whereas for buprenorphine, you can see it comes as a pair, and it costs about 2,000 rupees. That will be about 150 rupees per day. Whereas methadone, that will be comparable to morphine. So if you prescribe buprenorphine or fentanyl patch for a patient who is very poor, it is very unlikely that they are going to use it, and they may not use it properly. So all the problems. So please keep it in mind also. So I think I will stop here. Yeah.
Thank you, Sunil sir. Thank you so much for that very detailed presentation. I believe already when you were at halfway through the session, I think then also comments were coming that you were so experienced, and thank you so much for coming. So thank you so much. Do we have any further more queries regarding the session to be posted or to be asked to sir directly? We do have a case presentation as well. Sir, what is your opinion? Like, should we go ahead with the case presentation or?
If they have more questions, who is presenting today?
The case was is brought in by Dr. Roshan Kumar.
Yeah, Dr. Roshan Kumar, would you like to continue with the question answer session, or do you want to continue with the patient story?
So it's your call.
No, because it's your time now, so that's why I am asking you. Even I have taken enough time, or I exceeded the time.
Sir, in that case, may present the case so that maybe more queries will come based on
Yeah.
the case.
Okay. Yes, Dr. Roshan Kumar, you can continue your.
Hello, thank you so much, Pali Media, for giving an opportunity to present a case. Myself, Dr. Roshan Kumar, I'm consultant radiation oncologist in Nashik, CCA. Next case, this is a 45-year-old gentleman diagnosed with metastatic lung cancer. Metastasis to brain, bone, lungs, contractile lungs as well, and liver. It was like non-small cell. The patient was presented with some intractable pain, severe intractable pain at left hip. He was not able to move. He was in wheelchair, totally dependent. He was not that breathless, but yes, there was a kind of breathlessness, but he was stable. He has headache and a few sorts of vomiting the previous day. If history in illness, I mean, he was a known case of non-small cell lung with baseline PET CT showing visceral metastasis. There was a pathological fracture in the left femur because of he was in intractable pain, not able to sleep, not able to do daily works, totally dependent, and coming into the OPD with the wheelchair. And he was seen in the tumor board, and our primary plan was like to start palliative chemotherapy and as well as palliative radiation for pain. So he was referred by a medical oncologist, and which he was planning for pal chemotherapy. It was like oral chemotherapy only. So he was referred to me for pain management and palliative radiation. So on examination, this is a typo error. GC was not good. GC was in fair. KPS was 50. ECOG score like 3. Wheelchair bound. Paler was there. SCF was there. Vitals are quite stable at that point of time. There was tenderness at left hip, but I couldn't examine because of severe pain. He was wheelchair bound, and the distal neuropathy was not there. But in view of pain, he was not able to move his left leg. Investigation wise, I didn't ask for any major investigation as PET CT was done, biopsy with the IC was done already. So as far as the palliative palliation is concerned, I was okay with the already available investigations. So first of all, it was a pathological fracture which was causing a severe pain. So I have to discuss with orthopedician. But on paper, I have write referral to ortho, but there were two issues for me. First is financial thing. Second is logistic problem too, because we didn't have like in-house ortho guy. So we have to refer to another center for the fixing the fracture. So there was a financial issue. There was a logistic problem, and what my thought with the discussion with other colleagues in my hospital with the survival was less than 6 months, like the survival. So really, it was really questionable whether he's getting benefit from this kind of fixing thing. So we haven't referred immediately. And second thing, he was not in the condition to go for any kind of invasive procedure. So the plan was like get an on paper ortho opinion at least to give palliative radiation to hip and brain because he was having brain mets, and to start a good analgesics and to start a pal chemo thereafter. So psychological aspect, I have explained all about like cardiac prognosis, inform about the future plan, the overall prognosis, the need of treatment and precautions to be taken. He discussed about like his family and liabilities definitely, but I have my limitations in my OPD, so I refer to psycho-oncologist for the further counseling part. So psycho-social part, I could not, give that much of time to handle this aspect. Yeah, medication may I have started Narcogen 4. Actually, yesterday we have discussed the morphine is not that available, but we generally give a morphine plus paracetamol combination. Sorry, not morphine, codeine plus paracetamol combination with Narcogen 4, which I have personally a good experience with. It's like opioid, weak opioid level 2 the latter. So I started with Narcogen 4, Pan 40, Triptomer for 3 days because I don't want them to buy like 10 days medications, because if you want to escalate, then it will be a waste of money. So generally I give for 3 days for every patient, most of the patients, and evaluate after 3 days. Dexa I have added just because he was having the fracture. So to reduce that edema, and even Dexa acts as a good analgesic as per my experience. So I generally add Dexa. The second thing, he was having brain metastasis. To reduce that edema, the DEXA definitely helps. So DEXA, I start with BD and then will taper accordingly. But the pain was there, subsided, but definitely was there. Like from 9 out of 10, it was reduced to 7. So I have to change Narcogen to morphine the next day. Generally, in my practice, I am not that. I have not expert in the pain management, but generally what I do, like I started morphine 10 mg 4 times in a day, because 6 times is quite impossible for a patient, and 5 mg morphine for breakthrough pain, with continuing all other medications along with domperidone and bisacodyl. So my main concern are like, I should have started with level 3 first, question, or should we escalate from level 2 to level 3? Because I don't start with morphine directly, because I should have something in my hand in future. I mean, we should have some reserve analgesics. That's why my first personal approach is to start with second level and then go to third level 3. What about my daily morphine dose? Should I change my practice, the dosing practice? What about morphine SR? Because morphine SR is not available at my center. So morphine SR can be changed after 3 days. What if it's not controlled by morphine? And what about adjuvant? Should we escalate or de-escalate? And what about the invasive interventions? These were my main concerns. Next slide, please. Next. The discussion points, like I have to discuss about like these things. Should we start with directly to level 3 or level 2 to level 3? Should we escalate? What about adjunct escalation? What I should have fixed the pathological fracture or not? And sometimes my patient asks for low dose DIXA continuously, which I don't prefer, but somehow patient got good amount of relief with dexamethasone. So what to do with this kind of patients who hardly will live for more than a few months or so? Should we not care about the long-term side effects and give as per their demand? I mean, what should be the approach? Thank you so much.
Thank you, Dr. Roshan Kumar. So I would like to each of you or anyone comment on this questions. So what would you do if you were in Dr. Roshan's situation? Sorry, couldn't hear you.
Hello.
Yes.
Dr. Muninder, if you want to communicate something, I think multiple devices are there in the room where you are sitting. So you could mute the other devices and.
Okay, ma'am. Thank you.
Yes.
Yeah, you can talk now. Okay now.
As for this patient, this is a stage 4 disease with brain mets and multiple bone mets with pathological fracture. The survival of this patient is not more than 6 months. In my opinion, we will proceed through, first we will give the radiation to the single fraction, not 30 gray in 10 fractions, because of the logistic problem. And so many times you have to put the patient on the machine. So I will prefer single fraction to the pelvis in single fraction to the brain. I would like to give 20 fraction in 5 fraction. So the duration of treatment should be less. And then I will start with dexamethasone 1 day before giving the radiation. Radiation will increase the edema, it will aggravate the pain. And with that, I will also like to give pregabalin. That will help in the neurogenic pain with also the convulsions due to the second meds, brain meds. And then I will start with the morphine for the pain, and rest is Visacodil and all.
Okay, thank you, Dr. Muninder. Are you an oncologist?
Yeah, I am a radiation oncologist.
Okay, thank you. It's good to have you both here, Dr. Roshan as well as Dr. Muninder. So, anybody else have any opinion regarding the pain management?
Hello, I'm Dr. Mangli here.
Yes.
Actually, seeing the NRS score 9/10, it's a severe pain with bone mets and pathological fracture. So we need to respect the patient first. Then I think we should proceed with morphine 10 mg 4 hourly for breakthrough pain, another 10 mg if necessary. With that, we will give. I don't recommend radiation in this stage, because in this fourth stage of lung cancer with bone mets, the survival rate is very low. But what we can do by giving the morphine with gabapentin 100 mg thrice a daily with laxative, it will reduce some pain. For the metastasis and all, we can provide him with IV lignocaine for the better release of pain. And I think it will make him some relief from the pain. If we can reduce the pain more than 50% or 50%, it will help him survive through the process. Thank you.
Okay,
My
thank you, Dr.
Sir,
Yes, Dr. Maninder.
my question is, if you will not give the radiation to the brain, how will you manage the brain symptoms? By giving dexamethasone will not help that much.
So this patient has a metastatic cancer with pathological fracture of left hip as well as brain metastasis.
Brain metastasis.
For this patient, I think I would agree with Dr. Muninder that we should be able to give radiation to the hip, because it would be mostly incident pain, and it would be difficult to control with analgesic alone. So if the radiation has given and as told, I would also prefer maybe less number of fraction. So both of you would be the expert. I can't comment on that. Definitely I would take the help of a radiation oncologist because it is going to help the patient. Till that time, I think as the patient has very severe pain, if I have injection morphine, I would have given a morphine trial to see that how much morphine does the patient need, and is the pain completely responding to the opioid. Then I will start him on definitely on step 3 opioids. So that's what I would do. And regarding the radiation to brain, I think the opinion of the oncologist as well as the patient and family need to be considered, because we know that the survival is very less. So we know that it is going to control some of the brain symptoms of the patient, but does the patient also want that, family want that? This all need to be taken into consideration. Yes, prophylactic use of anticonvulsants are recommended for brain mets. Just my query.
So the evidence says unless otherwise we generally start with Levera 500 PD, but if you ask me the evidence says unless patient is having the convulsion episode, we should not start. There is no such benefit. But yeah, in practice, we start with Levera 500.
Yeah.
Sir, radiation will be altogether different topic. I will not discuss that.
That's
doctors.
what I believe.
But as far as the medical management is concerned, my primary question is like, how will you decide the dose of, the dose of morphine? Is it like we should start with 5 mg, or we should start with 10 mg, or we should start like IV trial and then decide?
No, if you have injectable morphine, I would advise you to give an injection morphine titration. Then you would know that how much morphine that patient requires. But if you don't have injection morphine, then if the patient is not on any opioid, that is, patient is not on narcogen 4, then I would start with 5 milligram of morphine. If the patient is on narcogen 4, then as you have started on 10 milligram, I would give 10 milligram 4 hourly. Mostly the pain at hip is nociceptive pain, because you said that it is at left hip, it is not no radiation to anybody. It is mostly a nociceptive pain, but bone pain can also be have a element of neuropathic pain. So maybe as you added amitriptyline or nortriptyline can also be helpful. And regarding the dose of dexamethasone, were you talking about the role of dexamethasone for pain relief?
Yes, sir. Kind of like if we have not have like brain meds, even if I'll start DEXA just because kind of there are soft tissue component that will reduce the edema and kind of component.
Yeah.
I mean reduce the pain component. But what is your experience? Do you start any kind of steroid as an analgesic somewhere point of time?
Yeah, there are patients. This patient, you can always try with steroid, and when you we taper it maybe after 3 to 5 days, and there are some patients who get good pain relief with the steroids only. They may not have good pain relief on any other medication. So in such patients, we would try to find out what would be the lowest dose of steroid that is going to be effective for this patient. So this patient is receiving 4 milligram BD. So we will try to reduce it to 2 milligram BD, and we'll see whether patient is getting the same pain relief. So we will reduce it and find out whether that is going to give good pain relief. And if we feel that, okay, this patient needs to be continued on long-term steroid. Some patients goes with a long-term steroid till the end. So give the lowest possible dose for the patient, because here we are focusing at comfort of the patient. We are trying
So
to
we won't.
Yeah.
Yeah. So we won't make it zero. We can maintain it at low dose with
You can maintain it at low dose, but if the pain is responding to opioids and radiation, then I would not continue with the steroids on a long-term basis. Otherwise,
Okay.
And regarding the patch, that we have already discussed, fentanyl patch. This is, one problem is the cost. And second problem is that if we have to find out whether the patient has a stabilized pain. If the patient has frequent increase of pain, and then after some time it reduces. So it is if it is an unstabilized pain, I would not advise the fentanyl patch. But if the patient is unable to swallow anything orally, maybe. And
Okay, so is there
yeah.
any criteria whether you will start morphine or you will prescribe the fentanyl patch if the financial constraint is not an issue? What is your take?
Yeah, both are good medications, but all over the world, morphine is the gold standard for pain management.
Okay. Thank you so much, sir.
Any invasive procedures, I'm not an expert in invasive pain management, but still, if the patient doesn't have any pain relief with radiation, all the opioids, adjuvants, steroids, NSAIDs, then I may go for an epidural, continuous epidural infusion of local anesthetic and morphine.
And one more thing which has been actually cleared in the lecture that I was worried about lung primary and lung meds. Respiratory depression is the issue from the morphine side point of view. So I got it clear now. Okay, it is actually a very uncommon event.
Yeah. And another thing is that actually morphine is used to treat breathlessness in patients who has where breathlessness is refractory to the conventional treatment. So I think morphine is a good choice here. So I think time is up now, and even it's 4:34. So thank you, Dr. Roshan Kumar, for bringing up that patient story. And it's very good to see that there are a lot of specialists from different specialties. And thank you for active participation. Cypriya, it's over to you.
Thank you, sir. Thank you. Since I have been seeing you regularly every day, I know how busy a person you are with the fellowship work and all. But still, you found out time for this cohort and interacted with us so much time. Thank you so much for that. And thank you each and every participant who made this interaction very lively. a very lively session, very active discussions. Thank you so much, and we hope to continue this till the end of our sessions. So, with that note, and reminding again humbly that please do leave your feedbacks because it is very valuable for us. It helps us to improve ourselves. With that note, this is Sri Priya along with Dr. Sunil Kumar signing off from the Tips Eco Hub. See you tomorrow with another active discussion on topic of difficult pain. Till then, everyone, take care, be happy. Bye bye.